Very important topic, the vascular imaging of pelvic congestion syndrome. We are all ears.
Thank you, Dr. for your kind introduction. I will now talk about a very interesting dark spots in our practice, how to examine and diagnose patients with pelvic congestion disorder. I have no disclosures to declare. So, it affects the female in a childbearing age. It was first described by Taylor in year 43. Most of the patients are suffering from pelvic pain, 15% of the patients. It has different differential diagnoses as endometriosis, uterine fibroids, pelvic malignancy, and pudendal nerve compression. Many symptoms, as chronic pelvic pain, heaviness, dysuria, dysmenorrhea, which is relieved when the patient changes to supine position, and mostly affect one side of the patient. Also, the effects with lower limb varicosities. So, let's start from the beginning. When we suspect that a patient is suffering from pelvic, we call it pelvic varices or pelvic congestion disorder, when we doing an lower limb varicose vein examination. Firstly, if we have a presence of varicose veins in the upper proximal thighs or the lateral thighs, we must suspect that you have a pelvic varices. Or also, if you have a typical pattern of varicose veins, which is not associated with truncal reflux, as Dr. Mendoza has explained to us previously, and mainly if you have a recurrent varicose veins, as Dr. Mendoza said before. So let's take about different pathologies. If we have a reflux in the great saphenous vein with competent saphenofemoral junction, most of the reflux is coming from a valvular or pelvic varices, or we have reflux in the anterior accessory or superficial accessory vein, and it's connected with the great saphenous vein also. It mostly comes from valvular varices, which we suspect a pelvic problem. Also, if we have a posterior varicosities related to the anal or valvular varicosities posteriorly, and it is a source of the flux in the vena Giacomini and the small saphenous vein. If we have multiple tiny veins on the lateral aspect of the gluteal region and the thigh, we must suspect the patient have a pelvic problem. And the recurrency. Mainly the cause of the recurrency is reflux from the pelvic-perineal region and of the new vascularity, which also comes from the pelvic-perineal regions. So if you have these patterns, we must proceed to examine the pelvis and the pelvic veins for exclusion of pelvic venous insufficiency. So it's classified by Greiner into type 1, which represents reflux only due to varicosis only due to the reflux in the gonadal or iliac veins. Type 2, it's because of obstruction at a higher level, at the level of iliac or renal veins. Type 3 is very rare due to other different pathologies. So I know it's a very busy slide, but I will go with you through it. So the main reason for consultation of the patient to us is having lower limb varicosities. So by clinical examination and researches, if we find a perineal or genital or inguinal varices, or we have a typical pattern of varicose veins or symptoms of pelvic congestion syndrome, we proceed by examination of the pelvic veins in this pattern, which I will explain later. If we have normal tests, so we go for treatment of the lower limb varices. If you have a pathological findings, either we have suspicion of obstructive syndrome type 2, we go for contrast angiography or CT or MRI, or we suspect a non-obstructive syndrome, we go for pelvic phlebography, and we can do embolization if we are interested in intervention radiology. So what's the principles of ultrasound examination? Step by step, we must go step by step, like we are going upstairs on a ladder. First, we search for varicose veins in the uterine area, in the parauterine area. Second, if we find a positive finding, we go to the gonadal veins to examine it. If we find positive finding of gonadal veins, we search for obstruction at the level of the left renal vein or at the level of the inguinal veins, obstructive disease like May-Turner or Nutcracker diseases. And finally, we search for the leaking point, which is a communicating perforating veins between the pelvic veins and the lower extremity veins. The reflux is graded on a scale from 1 to 4. Absent, 0. or not significant, which we call it mild intermittent reflux, less than 0.5 seconds. Significant, which we call it persistent reflux, either the entire length of the physical maneuvers as described or more than 0.5 seconds, or very significant, which is passive reflux without any provocative maneuvers, which lasts all the time of our examination. We have other findings to confirm our diagnosis. If we have dilatation of the ovarian veins equal or more than 6 millimeters. Also, if we have 4 or more parauterine or pelvic varices more than 4 millimeters. If we have a contralateral or ipsilateral siphon effect between the ovarian vein and the anterior iliac vein, which will I explain later. Also, if these varices have reflux pattern during the physical maneuvers. So let's start with examination. We will examine firstly the uterine area. We have different ways to explore this, either trans-abdominal or transperineal approach or transvaginal approach. The most accurate and detailed is the transvaginal approach, but yeah, maybe some of us have difficulties in doing this procedure with other patients. Let's start with transvaginal ultrasound. Here, most of us know this view. It's an axial view of the uterus. We can see here it's surrounded by multiple varices along the margins of the uterus. When we apply color Doppler, we see reflux during these veins. Most of the veins are dilated, more than 4 millimeters in diameter. So when we change our probe to the lateral fornix, either right or left fornix of the vagina, we can examine the ovarian vein, the para-ovarian plexus of veins, and the ovary. We can see here clearly the ovarian vein and the para-ovarian plexus veins. We can see here in this image huge dilatation of the ovarian vein with significant reflux. So we can examine this by trans-abdominal approach. Here the view, in the coronal view of the uterus, we can see here dilated varices, veins surrounding the uterus on the right side, on the left side. You can see here the diameter more than 6.5 millimeters. By color Doppler, we can see here is flow or reflux during respiration. Here is reflux across the arcuate veins of the surrounding the uterus. One of my cases, you can see here, there is dilatation of the parauterine vessels more than 6 millimeters. And in the real-time video, you can see here reflux during the inspiration. During expiration, you can see flow within the veins, which is indicative of reflux. When we find this, we proceed to examination of the gonadal veins, also trans-abdominally. Initially, we position the patient nearly sitting, like 80 degrees recumbent, to examine the upper abdominal vessels, like the renal veins. And then we change the position to a reclining position, 45 degrees, to examine the veins around below the umbilicus. We use, as we all know, the curvilinear transducer. We set the resolution. We set the PRF to the lowest possible to detect any flow within the parauterine vessels. Here is an illustration showing that the reflux is more common in the left renal vein. As we know, when we in males in varicocele, it's common to have a left varicocele more than right and more than bilateral. Also in the female, this is applied due to the anatomical variations of insertion of the gonadal veins. It's most common to find reflux in the left ovarian vein and the and left para-ovarian, maybe also bilateral, and there is the leaking points. This is a diagram showing the position of the ovarian vein in the transverse view. Here is the psoas muscle, iliac veins, upper abdominal level. We can see here that the ovarian vein is placed just anterior to the psoas muscle, and when we change our position more distally, more caudally towards the pelvis, we can see here that the vein is moving more medially towards the iliac veins. Here the origin or insertion of the ovarian vein, the left side, right side directly toward the IVC, the right side into left renal vein. One of my image, you can see here the right ovarian vein, small diameter, 2.7 millimeter. The left ovarian vein is dilated, 6.4 millimeter, and here we can see here obvious reflux during during inspiration and expiration, obvious reflux, as you can see. When you find these parameters, we are sure and we are confident to diagnose an ovarian vein reflux, because it's many of us, when they find only dilatation without detection of flux, they go for pelvic congestion, and it's give a misleading effect to the clinicians about the having pelvic congestion, because when we find para-ovarian varices, maybe other causes causing it, not always the left ovarian vein. So we have an evident reflux and dilatation of the vein to reach this diagnosis. We have also two types, obstructive or non-obstructive. So after this, we go to exclude the obstructive type, either at the level of the left ovarian vein. We call it, as we know, nutcracker syndrome. It's many types. The most common is compression of the left renal vein between the superior mesenteric artery and the aorta, and the posterior type, compression of the left renal vein posterior to the aorta and the vertebra, across the vertebra. The circumferential circumaortic left vein is very rare to diagnose. The same examination pattern as we do previously in the renal veins. The most important tip that I have to tell you, that never compress the abdomen. Most of us, we find gases, we use compression by the probe to remove the gases of the bowel. But it gives us a very false idea that the left renal vein is compressed. So when you do a light pressure, it's normal calibers. So misdiagnosing nutcracker disease is very common by only compressing the abdominal veins. You have to do a very light compression when you are examining the left renal vein. To reach a diagnosis, the ratio between the stenosed or narrowed segment to the normal segment must be more than 5. So to say this diagnosis, we have this ratio to confirm. We examine the renal vein in sagittal section by measuring the meso-aortic angle, the angle between the superior mesenteric and the aorta, normally between 30 to 60, 25 to 60 degrees. But when it's narrowed, like here, 16, we confirm we have compression of the renal vein. Maybe superior mesenteric syndrome may be considered also. We must use lateral physical maneuvers by moving the patient lateral decubitus either to the right or the left. We change the patient position to a trending bank position. We use a deep inspiration to cause venous filling of the renal vein to expand the vein. Also, we can use a Valsalva maneuver, but it's very rare because it causes movement of the abdomen and causing artifacts. Here, when we change the patients to lateral decubitus, you can see here that the compressed area, after we change the position, has retained its normal caliber. The same is here by using trending bank position. One of my cases, we can see here, there is significant compression at the level of the renal vein in the meso-aortic area. Here is the renal vein dilated, and here is the segment is very compressed and narrowed. Video showing us, here's an colored image showing there is a liaising and jet flow at this angle, confirming there is a compression on the renal vein. But when we move the patient to lateral decubitus, we can feel the release of compression. So the nutcracker disease is a functional positional compression. So when we move to the lateral side, the compression is relieved. It's not a permanent stenosis of the vein. So we must confirm this, because when the patient in fibrosis or permanent stenosis, it's more difficult to treat. So we must confirm our diagnosis by performing physical maneuvers to exclude permanent affection of the vein. We examine the iliac veins for May-Turner syndrome. May-Turner syndrome is also a compression syndrome. It's compression of the left iliac vein by the right common iliac artery. We also have clues, indirect signs, which may suggest this pathology. If we find very slow speed of flow within the common femoral vein in left side more than the right sides, the right side is normal and the left side is normal, we may suspect there is compression at the level of the iliac veins. We find a reversal of flow in the internal iliac vein on the left sides, and we find it normally, we suspect a May-Turner syndrome. Also, if we find collaterals at the iliac regions, like many collaterals, the collateral veins, we suspect a May-Turner syndrome. Also, we must have a light compression, also to never to perform a pseudo May-Turner by abdominal compression. One of my cases, you can see significant compression of the left renal vein by the artery. You can see the indentation, and there is the jet of aliasing due to the compression. Video showing this effect, aliasing and high velocity at the site of crossing. Also, by using pulsed Doppler, you can see here very high velocity. It's like an AV fistula due to the compression of this vein. Here is a reversal of flow of the left renal vein. You can see here the right internal iliac vein. Here is the left internal vein. You can see here reversal of flow compared to the artery. Look at this video. Here's the artery is blue and the vein is blue. So absolutely there is a refluxing flow. So you compare it to the artery, if the same color, you have a refluxing internal iliac vein. Finally, you search for the leak points. As Dr. Mendoza and Dr. Karim told us before, we have many points. We have the gluteal points, superior gluteal and inferior gluteal. We have the perineal point, we call it P point, most common refluxing point of communication between the pelvic veins and the leg veins. Also we have obturator, as Dr. Karim mentioned before, and inguinal point. The most common is the P point, which causes the valvular varices. A newly suggested point is gluteal joint, but it's very rare to find. Here the location of the P point of communication leaking points. Here is the location of the inguinal point, I point. But identification by ultrasound, gluteal, and the obturator is very difficult. We only identify it by angiographic studies, not by duplex. Here is the appearance of valvular varices, and as you know, here is the ultrasound appearance of this. Thank you very much for your attention. So, any questions for me?
Thank you very much, Professor Khaled. It was a very clear lecture with crystal clear elaborative pictures.
Thank you very much.
And really delivering the message crystal clear.
Thank you very much.
Now the floor is open for questions for Dr. Khaled.
I actually have a question about the reflux. Sometimes when we do by abdominal ultrasound, you can't find the reflux in the gonadal vein, especially when it is circumaortic, for example, or something, yes. But the patient has pelvic congestion syndrome, and when we go with the catheter, when you go deep, it is totally refluxing. Are there any tricks or maneuvers to show the reflux in the vein in these cases?
In the renal vein or in the renal?
In the gonadal.
Gonadal vein.
Yeah, yeah.
Changing the upright position. If you change the patient, like we do in the lower limbs, you usually examine the patient when he's sitting in a prone position, supine position, sorry, and you do this. You rarely find the reflux or very small reflux. When you change the patient while you are examining him in the upright position, sitting position, you will find absolute reflux. Any other questions from the floor? Yes, Dr. Mohammed, please.
You mentioned, Dr. Khaled, that patients with renal vein nutcracker, yes, usually you will find a supramesenteric artery nutcracker. Do you know the incidence?
Supramesenteric what?
Nutcrackers.
Yes.
This is a common finding?
It's a very rare finding, and I encourage my colleagues to never jump to this finding. It's very rare, as I believe.
But you advise if we find
this finding,
look for it.
Yeah, we must look for it because, as I told before, that we have two pathologies in the renal vein, either obstructive or refluxing only, and defect in the valves. So we find the reflux in the gonadal veins, we must examine the renal vein to exclude this pathology. But in my...
No, I mean, if you find a
renal vein compression,
yes, you will ask your colleagues to look for a supramesenteric artery nutcracker also?
Yeah, supramesenteric, like a supramesenteric syndrome. I think it's related to the complaint of the patient. If the patient is complaining of pelvic congestion syndrome or renal symptoms, it's only a compression of the renal vein. But if complaining of vomiting and other causes like compression, I understand the question, yes, or I'm answering another way. So I think it's related to the symptoms and complaints of the patients.
But not routinely you are looking for
No. It's guided by the patient complaints and the order of the physicians to measure the angle and looking for this compression syndromes. Thank you very much. Finally, the last but not the least, our